Hello, everyone. Welcome to another episode of the Blue Squad on Health, where old timers in the industry, I'm sorry, I shouldn't say old timers, but old timers in the industry come out and try to say things that they are seeing today and their opinions on it. But today we have a special guest. We have Jeff Sigman, Global Technology Officer of Arkos Health. He, like me and Andreas, has been around for a long time. He has seen everything. So today we are going to talk to him, and he's a big player. Arkos Health is a big player in value-based care enablement. So welcome to the show, Jeff. And if you want to give you an introduction about who you are, you may start now.
Excellent. And I would say experienced.
Sure. Sure.
Thank you, Shameem. Sure. Pleasure to be here. I've had a long career in tech-related organizations. As a matter of fact, I started way back running engineering for NBC. So I've got media, finance, communications, telco, and healthcare over the long career that I've had, and have held various positions, C-level as well as operational, and I'm kind of worked my way up through the chain of command. Several startups, several ended well, several didn't. As any entrepreneur will tell you, that's fairly normal. And in 2014, started a company called VisiHealth, and with two partners. I left. I went to run my consulting company and take other positions, but that eventually combined with UPMC and what was Arkos, UHS, and became Arkos Health in 2020. And Arkos Health has had fantastic growth. I joined at the latter part of 2022. First came in as a consultant, but I knew several of the C-suite, many of them. They knew me for a long time. And they brought me in to upgrade and enhance their technology. So I came in as global technology officer in late 22, redesigned pretty much everything, including how Blue interfaced with the rest of the organization. And here we are. I'm now the chief innovation officer. So I've kind of transitioned the company into latest and greatest capability. And now my focus is on AI, of course, and we're utilizing AI in all facets of our business. And so we've been using Blue for, I guess, 6 years, 7 years.
Something like that. But we'll get into the technology part. But when you talked about UPMC, it was kind of interesting, right? Because UPMC has a lot of, I call it a birthing center for entrepreneurial activity. They whip out companies. Our own journey was we started with a UPMC company called Kuravi. Kuravi later on merged with Arkos. So that's kind of interesting. So we all came from different paths, and the single unifying factor there was the UPMC piece of it. That was kind of interesting.
That's right. That's right. So what does Arkos do? Arkos is in value-based care. We've grown. Actually, we're number 13 on the Fortune 5,000 fastest growing company list. That's of late 24. Arkos is in 7 states. and has 12 lines of business. Our customers are the payers. We have most of the big ones. We manage about 450,000 members in Medicare, Medicaid, and Exchange Marketplace, or ACA. And Arkos is kind of unique because it's got kind of a 360 service set. Not only do we go out and we do annual wellness visits, whether they're telehealth or boots on the ground in-home visits by nurse practitioners. We have programs that drive better care, better outcomes, and fit right in with the value-based care model. We don't replace the PCP. We're an extension of the PCP to augment the patient's PCP relationship and drive wellness, right? Value-based care is really kind of driven by medical loss ratio and quality. So we pay a lot of attention to quality measures, things like, have you had your mammogram kind of today to yesterday, tomorrow? Have you scheduled it? If not, we have concierge services that can do that. We help patients with food insecurity, transportation issues, that sort of thing. So we're about 500 strong. And we also outsource some of our services, but always under the management of Arkos. And so as we kind of progressed with technology being an enabler, it's not a replacement for a human, but it's an enabler. We really have a focus on human first, right? And AI supporting that. Now, we do use AI outreach for scheduling, for instance, but that's on top of 100 call center agents. Okay.
So
Yeah.
just to have it as a discussion here, right? So for Andreas, right, for the European market, that's when we talk about Andreas, right, the American model of value-based care, right, that might be a little bit, we may have to mansplain it a little bit, right? Or do we? I'm going to leave that to Andreas and you can ask those questions. And on that front, on the second front, what I wanted to really talk about was in value-based care, everybody knows that it's based on the outcomes, right? So when it was the olden days, let's go back to the original doctor-patient relationship when they were living in small villages. You had a local doctor who goes in and he's responsible for the health of most of the people in the village. So he goes there, he makes house calls to see how is Mary doing or how is Francis doing and everything. So he is there. But as things progress, as population increase, that kind of personal attention couldn't be done. But when technology came in, that same level of attention can now be given at this stage because of the advances of technology. So where am I going with this? Is it possible to implement value-based care models without the help of current technology? That was one of the main questions that we are asking. Is it so? You are managing 450,000 members, right? I don't think it. Maybe I shouldn't tilt the balance or press my thumb on the scale here, but is it possible to do the same level of service without the help of technology? Of course, you have all these people, 500 people. It's not a small thing, but isn't technology a very critical part in how you are doing value-based care? And guys, feel free to ask any questions because we have somebody here. And if he doesn't know, he will say he doesn't know. That's fine, right?
But I will. Well, look, as I said, technology is an enabler. It's a scaler. and it gives you insights and efficiency. It doesn't replace the person going into the home, let's call it the nurse practitioner going into the home. And when I say we're an extension of the PCP, that's part of what I mean. So, especially with Medicare, Medicaid type seniors, the home visit, the boots on the ground, enabled by the technology, you'd probably need double, triple the manpower, right? And then everything from your scheduling systems, your analytics, your stratification, right? Your risk identification, right? From an analytics perspective, okay? We use John Hopkins ACG, right? For risk analysis. We use a couple of other methodologies as well, but we stratify against the patient's history. We engage with the patient, and technology makes that stratification more efficient, effective. It makes the visit more efficient and effective. And then the follow up, because it's all about ongoing support, right? To keep people out of the hospital, to keep them out of the ER, to keep that connection into the PCP going. Technology enables that. And from a business model, if you kind of segment the platforms that are involved, you've got your engagement capabilities, right? Whether it be telehealth or text messaging or secure messaging or portals. You've got your operational support systems like your EHR, right? Your workflow automation, notifications, right? You've got your analytics, which kind of come in pre and post engagement, right? And you've got your scheduling and just the operational aspects of a large field-based workforce to make it as efficient as you can and most cost effective for both the business and for our customers as well as our patients. So there's really kind of a triangle of value. If you look at it, you've got the member, you've got the PCP, and you've got the payer. And we're the connective tissue between the three.
I don't want to monopolize the questions. If you guys have anything, I'm going to pause.
Yeah, I think having Jeff here, who's really knee deep in VBC, one of the things that I wanted to talk about was if you really look at a journey of VBC, right, the concept has been there for 20, 25 or 30 years from the beginning itself, provide value. But if you look at it, 15 years back, MU came in where the providers were driven through quality metrics, be it diabetic foot exams or things like that. Then there was cluster organizations put by the government like FQHCs and different models, right? Then they brought in the ACOs. So I think in the beginning period of my career, I saw a consolidation of services, and then it started decentralizing in a big way. There is PCMH or different things. Now there's a concept of where I think with the VBC payment models, it's really becoming more dissected into best of breed delivery. So the PCP looks at the point of care when the patient is there. After that, it's enablers to a large extent, right? And you did mention your customer is the payer, right? How does the ACO model, the FQHC model, or the new, behavioral health, models all, how do you see that all coming together with the concept of centralized care or decentralized care? And how do you see that managed services, all of this coming together today and tomorrow in the future? from a VBC?
That's a pretty large question, but let me try to unpack it. I'll tell you what I
He's
don't
trying
know.
to get you, Jeff. He's
No,
trying
no,
to
no, no, no.
get
I
you.
mean, I think Jeff.
No, it's
has a lot
okay.
of-
And you know, I'm a technology expert, right? But you've got to understand your business if you're gonna drive and lead, right? Innovation and technology. So, you know, and that's really it's a good question because however the first of all, paying for quality and outcomes in a value-based care model is the only way to go to drive that quality and to ensure that patients get the level of care that they require. Now, you also have your docs. I go to my PCP. He's sitting in front of a computer and checking all the boxes and making sure I'm getting all the tests and whatnot, but very comprehensive. Now, with technology, I've got another doctor that uses voice AI for transcription and note taking, right? So I'm kind of weaving the technology in here. So as we look at the ACOs and the system owned physician groups per se, which you're seeing a lot of that, they're all driving towards the same outcome. And that is better care for the patient, always paramount, right? But cost effective, right? Impactful. And technology allows you to really do that at scale because we wouldn't be able to do the coordination we need. You hear a lot about AI replacing people. No, it's going to augment in healthcare. It's going to augment the human to be more productive, to provide better care, to scale that care. So, you know, as you look at the different in the evolution of the market, that's why Arkos is here since 2020 to make that connection, whether it be an ACO, which we have as we service, whether it be a payer, whether it be an individual physician. And by the way, the individual physicians are the most loaded, right? Because they don't have if they're not in a group, many are, they don't have the infrastructure and the technology to be able to keep up. And, you know, so what we're all about is enabling the healthcare ecosystem to be able to scale, communicate, and engage with the patient because it all starts with engaging the patient.
So follow-up question on this thing, right? So the other day, I was being interviewed by I don't remember who. So and you said the same point earlier. There is the analysis, risk assessment before you take in a patient, or you start you know, for lack of a better word, right now
Providing
operating.
services, I think, is
Operating on a patient is basically providing those services. There's an assessment. And then at the end of the day, there is another measuring. So it's kind of like that famous book, Measure What Matters. Right? You start, you end, you see the difference. Have we succeeded or have we failed, right? Now, so far, most of the VBC technology companies that I've seen have gone into this analysis phase where they are able to pull in data from multiple sources, bring it and see the assessment of the risk score, and then to measure the outcome. What I have not seen, and which of course, you know, our company is focusing, is on the execution of a plan. So if you have a member, you brought them in, you have a care pathway or a care plan specifically for a group or a particular individual. that needs to be executed, and you should have a good system, whether it is AI or the old methodology. And it's so going back to what one of the interviews, this guy, Satya Nadella, was saying, the companies in AI that are really going to be providing value is the one who will help in the operationalizing their activities, right? So the task execution part of it. So in your experience with Arkos and other things, and you have implemented, I don't know whether this is protected information. I'm not. I mean, it's on your website, so I can say it. You have implemented Arkos 360 using the Salesforce platform. Of course, our platform is
As one
also
component.
right. Yeah. So one of the components is Salesforce. One of the components is our clinical piece from Blue EHR. Then there's other components. So when you looked into the market, you did not find a single solution that will help you execute your entire plan, right? So you had to put together all these things, all these components. Is it possible for you to tell us what are those areas, not the specific components that you use, the areas where you need a technology assistance that will help you in running? I think that is more your lane.
Okay. So let's start. I'm going to go two ways. I'm going to go from a kind of a tech perspective, and I'm going to go from a patient journey perspective, because it's all about supporting the patient journey, right? And so you want large areas. So we've got data ingestion. We take in massive amounts of data for our members. It's claims, it's real-time alerts, okay? If they discharge, if they show up at the ER, if they get admitted, we know through these HIE alerts. So it's a massive amount of data that has to be ingested, processed, and then stored for use, right? So think about it as a workflow. You ingest your data. We also have a data warehouse that we deposit that data in. And then Arkos 360, sometimes it wires off to the data warehouse into Arkos 360 or Salesforce as the experience engine. Okay. And from there, it goes into the clinical engine, which is currently Blue. And once that data is in, we then pass it through our business intelligence capability. So business intelligence is kind of post looking back historically on how did we perform, what's the reporting on that analysis, then kind of projecting where we should go based on data. So it's data-driven insights that really drive the business. Okay. And then once that's done, you've got your operational platforms, applications, and we're sprinkling AI along that route, right? Our call center, our AI will outreach. Okay. We get engagement there. Then we get schedule to engage. At that point, we can use telehealth. Again, we can use a schedule an in-home visit, which is very, very important because there's nothing like, value-based care is not just diagnoses that you have. It's SDOH, it's social drivers, it's housing, food insecurity, transportation, as I said. So if you really want to make an impact on a patient and then an overall population, because we are in population health, right? You've got to take these best practices that are all enabled with technology. And so you mentioned I couldn't find one solution. No, I couldn't. So what I did was, or what we did was, we used best of breed solutions with Arkos IP to tie it all together. Okay. We've developed lots of code, and the reason why actually we chose Salesforce, for instance, is it's really an innovation platform. I don't use it. I do use it as somewhat as a CRM, but that CRM traditional, that's the patient, right? Although they're not the quote unquote customer, in a way they are, but when you look at a member, you want a longitudinal view of that member with the data that's coming in, with the interactions that we have, that the others in the ecosystem have. And then you've got, it kind of just flows. And then for your clinical point of care, you want to have a platform that is flexible, that is API based, because in order to pull off a best of breed with Arkos IP wrapper, you've got to have components that talk to each other. And that's enabled through APIs. So we have a very robust API capability. In addition to the data ingestion, it's data integration. Okay. And so whether it be an EMR, a data service, fax service, call it what you like, it was all about enabling the business for the operational workflows, the data coming in, the analysis, right? And then the ability to apply that to a point of care encounter and make that point of care encounter most effective.
The last sentence was really very good summary, right? The data coming in, the analysis, and the workflow. These are the three core areas that you have to really be focusing on in this thing. So when you talk about the data coming in, we are talking about good integration capabilities, right? And then analysis is, of course, the good analytical capabilities and the workflow. And that is where, like, we specialize in that. And that's what the next question is. And the follow-up question is, now, each value-based care organization or our value-based care enabler have different workflows, right? And the system should be able to adapt to these kind of workflows. No, so you have to be innovative in your workflows, right? And that's why you said it has to be flexible, and of course the integration pieces of it, right? Right. Shahzad, Andreas, sorry. Usually Andreas is the one who monopolizes this conversation. I think
exactly. I'm holding back. So no, but I thank you for this very, very comprehensive summary, because that was one of the questions I had on my mind as well. You said in the very beginning, when you came in I think 2022 or something, you redesigned basically everything, which means you had to build infrastructure. And that's very interesting to me, because if I look across European markets, which are usually much smaller than the US market, and there is huge differences, and all of them, they report that at some point technology, data exchange, healthcare data policies, and so on, that's our main struggle when it comes to changing healthcare systems or implementing value-based models. I have one question on my mind in that context. Yeah, if you're getting paid by the quality your organization delivers, and all these technology efforts, you take them on in order to be able to transparently communicate what quality you have. Now, in that context, what kind of metrics or what kind of measurements are actually the key indicators in interaction with the payment model at the end of the day
KPIs.
to get this done? Yes.
Yes. Value-based care is pretty standardized in the fact that there's probably three major KPIs or components. One is overarching called MLR, medical loss ratio. And really that's revenue against cost. Are you in a surplus or deficit? Okay. And so if you're a risk-bearing organization, like we are, some aren't, and there's hybrid models that we do as well. Some are full risk, some are partial risk, right? And what does risk mean? It means you sign up for a certain level of MLR, let's say 85%, right? Which means your costs are in line with your revenue, right? And if it goes above it, we bear the burden. And if it goes below it,
You go celebrate.
we enjoy the surplus. So that's one. That's an overarching one. And so you can imagine how much analytics we're doing against revenue and cost to try to optimize that, right? As well as provide excellent care. And what goes into that? Well, in value-based care, there's two major points. There's HCC or care gaps. So you need to identify diagnoses. Let's say someone's on insulin, but they don't have a diabetic diagnosis, right? You got to make sure that that's all captured, right? And that's the benefit of annual health assessments, right? Or wellness assessments, comprehensive health assessments. There's 14 different acronyms, but basically, at the beginning, it depends on the line of business, Medicare, Medicaid, or exchange. But you've got your care gaps, which we identify and close. So, for instance, we will analyze through AI and NLP charts that we go out and get, right, for the patient to ensure we have retrospective and prospective views of the care gaps that have been identified. Are they still there? Really the diagnoses, right? To ensure we've got a 360 full view, full continuum is probably a better word, of the patient's health. And we make sure that those are identified and addressed. And that will drive wellness, and it also drives a revenue component, right? From a reimbursement perspective, the way it works is if you identify more and the person's sicker, the government will pay more for that member, and it's called a RAF score, risk adjustment factor, pretty sure. Which the higher it is, the higher the reimbursement for the patient, for the member is. So then you've got quality, HEDIS measures. And so quality is, just as a simple example, have you had your annual mammogram? And if you ensure it's a 5-star rating scale, and so in value-based care, if you can kind of get that population up in the stars, there's, of course, additional wellness, but also additional remuneration throughout the ecosystem. Everybody strives to be a 5-star quality organization. So those are the metrics, the MLR, the HCC, care gaps, and the HEDIS measures. Does that make sense?
Yeah, I think there is one underlying aspect of it, and Sam, you remember we discussed this several times. It's actually we always make fun of the facts that healthcare in our markets here is actually sick care. So you only take care of people if they enter your door with symptoms.
Oh,
But
we
just-
were the Americans. We were the kings of that until recently. That's what we are trying to move away from. So don't take that credit away from us.
Okay, but it might remain present on our shoulders if we don't move in our systems. Yeah, but the risk bearing aspect or taking on risk is actually incentivizing keeping people healthy. Yeah,
Absolutely.
that's one aspect of it, and the quality aspect you mentioned is basically, let's say, adherence to guidelines or adherence to screening programs and so
That's
on.
right.
And if you have 80% of your members not being adherent to these programs, assuming there is a rational way they have their thresholds or their heartbeat or whatever, that probably drives quality at the end of the day. Yeah,
It does. It drives wellness. It drives quality. It reduces cost on the overall healthcare in the overall healthcare system, right? Because the higher the wellness factor, the lower the cost, right? And then in value-based care for physicians, you're actually going to make more money if you keep your patients well, right? So I get, pestered by my PCP. Did you have this screening? Did you have that screening? Right? And it's definitely the right thing to do, right? But there's now incentive under value-based care to not just treat the symptoms and have your annual wellness visit or every 3 months or whatever it is, because the technology, and I'm not talking about, I'm talking about medical technology, biotech, in a sense, has really come a long way. You know, you can walk into a local orthopedic office and get a PRP and stem cell shot in your hip, and you don't have to go directly to the hip replacement. You're seeing tremendous strides on the biotech side. And what we do is we use, and that's really very, very much AI driven. We're using AI where we can to identify risk, to engage with patients, and to optimize workflows. And so, yeah.
When you talked about the RAF, right? I think you read RAF. You must have read recently about the big scandal that happened with, I think, United Healthcare, where they went ahead and was just diagnosing patients with new diseases, and they got like $1.5 billion. So that's another aspect that is, everything can lead to these kind of corruptions, but that was not the point of this discussion.
That doesn't happen in Arkos, by the
Oh,
way.
right.
Yeah, it's not, we do these things for wellness, and we are a business, so we want to. It's a beautiful kind of model because the better we do or the physician does financially, the wellness factor, the better the patient does, typically in value-based care, hence value-based care. Right.
The question that I was going to ask is when you talked about your implementing AI in many of these workflow solutions, right? And we are doing that too. So the question is, one, how much of an appetite is there among organizations to start using AI, not experimenting it, to use it in actual day-to-day activities, right? And so that is one. On the second side, I see that it's easier to implement AI in common things like scheduling or those kind of things. But in clinical side, isn't there a lot of certifications that is required? Is it now being asked to be certified as a class 2 medical device and these kind of things? So in your journey of implementing AI through your organization, have you classified these AI agents, if you will, as separate segments, or you went with the low-hanging fruit where you don't need these certifications?
No, we're not using it it doesn't replace a human at the clinical point of
No,
care level,
understood. Even
right?
without that.
First of all, it's a two-part question. Your first part, tremendous demand. It's obvious. I mean, anyone that's used ChatGPT, like it's like 5 assistants, right? I mean, and it knows everything. And so, depending upon the role, AI plays a different function. We are using or testing AI from a clinical perspective to predict performance of a patient, likelihood of admittance. We're even testing AI that you're on what patients would benefit most from Ozempic per se, right? And that's not directly in our wheelhouse, but you could extrapolate that to physical therapy or what patients are most likely to be food insecure, right? So that identification using AI is great. Now on the clinical side, we're using it for, as I said, HCC, care gap, and HEDIS measure identification, because there's a massive amount of data. There's claims, there's charts, there's alerts, there's all sorts of data, and it's all kind of spread around. And so AI is optimally useful or built to take all that data and very quickly output what you're looking for, whether it be what patients are most likely to go to the hospital, what patients are most likely to use the ER as a doctor's office, what patients haven't been to their PCP in the last 3, 6, 9, 12 months. Like this at your fingertips. So you've got the clinical, how will this drug kind of affect the population? You've got the workflow enhancements, augmentation, and optimization that AI can do. And you have the analytics, retrospective, prospective analytics, which is huge, because when I walked into Arkos, in the first 10 minutes, data-driven insights, kind of a light bulb went off. And that's really the truth. If you can derive insights from data, and what's better to do that than AI, then you can optimize your workflows, field staff, and operational activities all based on that data, right?
And even those agents, sorry, Andreas, you were going to ask something.
Yeah, if I listen to all these explanations, I become aware of I think 2 things, yeah, which seem to be very important. One is, and I think that's a little bit our European view on things, that there is one patient goes through the system, it goes through processes, and you mentioned that longitudinal view of a patient which you have in your system, powered by by Salesforce and other components. Yeah, and I think what we are missing often is that longitudinal view for one patient already, because what happens if they change between different providers, and we are not necessarily in these systems where one provider takes care 360 degrees for one person. Yeah? But the other aspect, and I think that's the one which brings in the value-based aspect, that's actually the population, the analytics aspect across all these longitudinal patient journeys. And if I listen to you, it's the based aspect of the story is not necessarily optimizing value for the individual patient, but for the patient population under management.
Which trickles down to the patient. Of course, you want to optimize the care for the individual patient, right? But you're dealing with a large population, right? And so every patient gets a one-on-one with the same kind of analysis, services, post-discharge, come out of the hospital, we're there for them, right? But you've also got to you've got to have another view. It can't be just you have a symptom, call us up and we'll come. You've got to be proactive from a population perspective to get ahead of though we'll get ahead of 100%, but if you can reduce ER visits by 50%, it's huge. It's huge. So that's the story.
And I believe, Andreas, looking at Europe and America, right? In America, the infrastructure and the policy has been going on for the last 30, 40 years. I think the government has made infrastructure which is enabling these things to happen. Be it the HIEs, be it the direct project, be it having standardization of billing, be it have one form to bill, be it the HEDIS scores, the RAF strategy, whatever it is. I think the government is putting infrastructure and then driving policy like VBC to actually be fruitful to achieve what they're trying to really do. Because at the end of the day, the government wants to reduce cost and make patients healthier, right? So I think that infrastructure and policy is what is enabling.
It's a driver.
It's a huge driver.
Yeah, and that's why I call technology but an enabler, right? Yep. It's not. It's not the prime. It's enabling these care services. It's enabling
the way they are doing it. The big teeth or the big weapon they have is the Medicaid and Medicare, which is the largest insurer in the country. So when they make those changes, even value-based care is driven by Medicare. Most of it, right? It is very little. I mean, correct me if I'm wrong, Jeff, comes from private insurance companies, right? The Medicare Advantage, Medicare, Medicaid, those are the ones that are driving most of these value-based care currently.
They're huge populations, but you're seeing more and more physician groups, for instance. 100 physician groups do a value-based care arrangement with the insurance companies. And the PCP I go to is under a value-based care model. Okay. And I have commercial insurance. So you're seeing, because it makes sense, risk-bearing entities tend to perform better.
No, the point I was trying to make is the US has been successful because they had this big leverage on doing that. And now people are adapting, many of them. And that's a good thing. But Andreas, to you, the question is, does Europe have something like that they can really weaponize to affect these kind of changes? Or individual countries might have those kind of things. I know in Switzerland, it is, everybody says Switzerland is the best place. I think it is even worse than the US. It's still fee for service. We live there, you and I. So
it's extremely, Switzerland is extremely fee for service. I would say, I don't know if I'm wrong saying that, but I think Switzerland is probably, when it comes to healthcare cost per person or per citizen, it's probably the closest to the US level compared to all other European countries. If you look,
and that's why I felt at home in Switzerland, right? In a negative way.
I mean, Switzerland has another aspect that there is a lot of wealth, and I would say that the whole system is in a way that we can afford this. But if you look across Europe, you see, for example, probably the Netherlands are the front runners in terms of value-based care. And that's why I asked these questions before, because what you see in the Netherlands is they went kind of nationwide to build a widespread outcome measurement system, for example. Yeah, and they put to what you mentioned, Shahzad, they put infrastructure in place enabling value-based care models. Yeah. The second struggle we are having in Europe is often kind of public healthcare systems. Yeah. In Switzerland, for example, you have a fee-for-service system, which is your ground stock in your health insurance, which you cannot negotiate. It doesn't go away. So if you come now with a value-based model and you want to interfere with that aspect, you're actually interfering with everything. Yeah? So this is kind of what hinders, be it incremental or disruptive innovation in this area. Yeah. And I mean, if you look at the different political discussions in these different countries, I think this has been seen in all these markets. Yeah, that what usually happens is you have an organization who is responsible to deliver care, which is at the end of the day fee-for-service models. They get more and more and more expensive, and you have payer organizations who just need to budget more, meaning you need to pay a higher premium every year for your health insurance, and that's what's happening and what cannot continue. Yeah, and I think that's driving things at the end of the day. What I would be interested in Arkos is actually, so the interaction with your payers or payment models is actually everything under such a value-based payment model, or do you have a portion which is still...
It varies. Yeah, there's certain pieces that may be included, maybe not. Part D, drug, it varies based on contract. Gentlemen, I apologize, but I gotta run.
Right. It's. I was going to say. So I think we have covered most of the stuff here. So I think I want to thank you for taking this
My pleasure.
meeting and having this discussion. Thank you all, and thanks everyone for watching. And we'll come back with more game changers in the future, hopefully, if they
Good to see you.
accept our invitation.